Hi everyone, welcome. We'll kick off in just a few minutes, just a few seconds actually, just to make sure everyone has enough time to jump on board, get in. Excellent. All right, well, I think we should kick off. Good afternoon, everybody. Welcome to today's webinar, the Lymphoedema Care and Vascular Disease Management. My name is Ryan. I'm the Marketing Manager for SSS Australia. Just a few housekeeping matters before we kick off today's presentation. This webinar is being recorded and will be available for viewing by our SSS Australia customers after the presentation. We should have a decent amount of time at the end of the webinar for a Q&A session. So if you think of any questions during the presentation, please pop them into the chat box and we'll try to get to them all at the end. If we don't get to them all at the end, we'll send out an email after the webinar, and that'll have all the questions with written answers as well in it. Do keep an eye on the chat as well. We'll be posting a link in there towards the end of the presentation that goes to the feedback form that we usually do after all of our webinars. Filling out that form is, how you can let us know how we went and how the session was, as well as how you can request your attendance certificate for your CPD points. All right, I'd like to introduce our speaker for today, Jackie Butel, founder of Lymphedema Therapy Training and Education. Jackie is a nationally and internationally recognized lymphedema expert with a passion for improving patient outcomes. Jackie is a registered nurse and decongestive lymphatic therapist with over 20 years career experience in treatment, training, and education related to lymphedema. I would also like to thank our sponsors for their support of today's webinar, SD and Ego. SD's family of Jobs products have compression solutions for every situation. Feel uplifted regardless of your lymphatic condition by choosing the right compression garment from their vast variety of Jobs products to counteract swelling. And Ego's QV Derm Care range of moisturizers and soap-free cleansers are clinically tested for use on mild to moderate eczema skin and have been shown to significantly improve the skin barrier function in just 28 days. For more information about these products, that'll be in the email that goes out after this, or you can reach out to your personal account manager. All right, without further ado, I'll pass it over to Jackie to get started. Thanks, Jackie.
Thank you, Ryan. So today we're going to have a quick chat about lymphedema care in vascular disease management. This is a really big topic and 1 hour is probably not going to do it justice, but I'm going to do my best. I also talk really quickly, so the benefit of having a replay is you can slow me right down, but I do have a lot to say, and I'm going to be using my notes just so I keep on track. As Ryan mentioned, I am a registered nurse and a decongestive lymphatic therapist. I provide a decongestive lymphatic therapy practitioner course, which is accredited by the Australasian Lymphology Association. So I spend a lot of my time with this demographic. Just a quick disclaimer, so this material is for informational purposes only. It does not replace the advice or counsel of a doctor or healthcare professional. SSS Australia and myself make every effort to provide information that's accurate and timely, but we make no guarantee in that regard, and you should consult with or rely on the advice of your physician or healthcare professional. And if you've got anything else to add to my content, I'd love to hear from you. So let's get started. So our learning outcomes for today, we're going to have a look at the relationship between vascular disease and lymphedema. A little bit of a look at the ABPI, or the Ankle-Brachial Pressure Index, in our clinical practice, and how to develop a tailored lymphedema management plan, implementing that best practice for wound care for our patients, looking at multidisciplinary teams and the power of being in one, educating and empowering our patients, and recognise the importance of continuing learning for lymphedema and vascular patients. So the most common type of chronic wound managed in the Australian primary care setting is our venous leg ulcers, which account for up to 70% of chronic wounds. So these are underdiagnosed and undertreated and cost the Australian healthcare system millions of dollars every year. Our treatment regimes basically include dressings, which is 76%, pharmacology is another 25%, medical compression is a woeful 2%. Now, medical compression, once peripheral artery disease has been ruled out, is our gold standard for treating vascular disease or wounds in our for the legs, and then referral out to other people like our vascular surgeons, wound nurses, like specific wound nurses, dietitians, podiatrists is only like 4.9%. So the gold standard treatment for each of these conditions is compression therapy, and yet it's rarely offered to our patients. It seems so simple, so why isn't it offered? Well, from the clinician's point of view, maybe there's some lack of training and awareness on the guidelines. And so a lot of time we use tubie grip or which causes that champagne leg or tourniqueting in our patients, and it's not that great. But then patients are also non-compliant, so they complain that compression's too hot, it's too hard to don, and it's quite expensive. So if a patient has or they're at risk of a lower extremity wound, they should expect to receive an ABPI within 4 weeks. And that is to rule out peripheral artery disease so that we can then look at our first line of treatment, which would be wound management and compression garments. So as clinicians, we need to utilise that MDT team, which would be people from our GPs, our vascular surgeons, our lymphedema therapists, and our wound nurses. Our patients should expect to have their wounds healed in a timely manner, but to do this, we need to make sure that we've taken a full health history, performed a visual and palpatory vascular assessment, perform an ABPI. So not just feeling for pedal pulses. A lot of the time we find our medical professionals will feel for those pedal pulses. If they're present and of a reasonable amplitude, then they will rule out peripheral artery disease. Pedal pulses, that presence is not an indicator for ruling out peripheral artery disease. And I know this because I have quite good pedal pulses and I have peripheral artery disease. So we also need to look at our multidisciplinary team, like referring out to vascular surgeons, podiatrists, dietitians, our lymphedema therapists, and our wound nurses. But most of all, our patients need to be compliant. And of course, we need to follow the appropriate pathways for referral and stay within our scope of practice. So as I'm talking through this webinar, I might say things that aren't in your scope of practice or that we should follow that referral pathway. It's an assumption that you would understand that we need to follow those guidelines. So understanding the role or understanding the relationship between vascular disease and lymphedema. So just as a quick recap, because you're probably all very well aware of this, the human circulatory and lymphatic systems, they work in tandem to maintain our fluid balance, our immune function, and our overall health. However, when vascular disease disrupts normal blood flow, it can have a profound effect on the lymphatic system, potentially leading to or exacerbating lymphedema. And so understanding this relationship is crucial if we're going to have an effective management and prevention of complications for our patients. So that relationship between vascular disease and lymphedema underscores the importance of early diagnosis, patient education, and an holistic approach to care. By addressing both those conditions simultaneously, healthcare providers can improve outcomes and enhance the quality of life for affected individuals. And in this picture here, a brand new therapist may jump to the conclusion that this lady possibly has lipedema because of the cuffing around the ankles. Not understanding that with venous disease, we have that pooling of blood at the ankles. And so she's got a normal ABPI. She's in compression stockings. Now, these stockings are too high on her leg. They should be 2 fingers below her popliteal so that that crease doesn't get into her knee crease when she's walking or sitting. And then we'd also need to make sure that we monitor those creases at her ankles. But this is just a quick photo to show you, a compression stocking and vascular disease. She was fitted correctly and she is seeing a vascular surgeon as well. So the vascular system comprises of arteries, veins and capillaries, and it's responsible for transporting oxygen, nutrients and our waste products throughout the body. So when vascular disease occurs, such as chronic venous insufficiency, deep vein thrombosis or PAD, peripheral artery disease, it can impair the blood flow and increase pressure in the veins. And this can lead to fluid leakage into surrounding tissues, overwhelming the lymphatic system, which can lead to lymphedema. And when it becomes too bad, we can have little splits in the skin where the lymphatic fluid leaks out of the skin, and that's called lymphorrhea. And the best way to fix that is compression therapy once we've ruled out peripheral artery disease. So everything about our legs and treatment basically comes back to best practice, which is an ABPI, Ankle-Brachial Pressure Index reading for that lower extremity, whether we're putting them into some compression garments or compression bandaging or looking at our wound management. That'll help inform our treatment. So chronic venous insufficiency occurs when the veins in the legs fail to efficiently return blood to the heart, leading to pooling of blood and increased pressure in the veins. And this can result in swelling, skin changes, and in severe cases, lymphedema. The lymphatic system may struggle to manage the increased fluid load, which leads to more chronic swelling and tissue damage. Regarding DVT, so that involves the formation of blood clots in deep veins, which we often find in the legs, and these clots can obstruct blood flow, increasing venous pressure, causing fluid to accumulate in the tissues, and if that lymphatic system is unable to compensate, then lymphedema is going to develop or may develop. Regarding PAD, this is characterised by reduced blood flow to the extremities due to narrowing or blocking of the arteries, which can also impact the lymphatic system, and that poor circulation can lead to tissue damage and inflammation, which may compromise lymphatic function and contribute to swelling. So how does compression therapy help these three conditions? Is it even safe to offer compression therapy? And we're going to talk a little bit about that during this hour. Alrighty, so vascular diseases, particularly that venous insufficiency, can cause an abnormal accumulation of fluid in that interstitial space. The lymphatic system, which is responsible for draining that fluid or that excess fluid, it's going to become overwhelmed, which will then lead to lymphedema. Chronic vascular conditions can trigger inflammation, which damages our lymphatic vessels and reduces their ability to transport lymph fluid. And so over time, this can result in fibrosis, which is a thickening and or scarring of the tissue, and that further impairs our lymphatic function. In some cases, vascular disease can directly affect the lymphatic vessels. For example, venous hypertension caused by chronic venous insufficiency can lead to structural changes in that lymphatic vessel, reducing their efficiency and contributing to lymphedema. So individuals who have experienced DVT or deep vein thrombosis may develop post-thrombotic syndrome, which is a condition characterised by chronic pain, swelling and skin changes. And PTS can compromise lymphatic drainage, increasing the risk of secondary lymphedema. So all of these things can lead to lymphedema. So lymphedema can also affect our vascular health. Chronic swelling and tissue changes associated with lymphedema can increase the risk of infection, such as cellulitis, which can further compromise vascular and lymphatic function. And additionally, prolonged lymphedema can lead to fibrosis, which may impair blood flow and exacerbate vascular issues. Someone with fibrosis is also going to be difficult to perform an ABPI on because their legs are so hard that we're not going to be able to get a blood pressure reading. So early diagnosis and a multidisciplinary approach are crucial for managing the relationship between vascular disease and lymphedema, and we need to have collaboration between all of our specialists, so vascular specialists, lymphedema therapists, and other healthcare providers such as our GPs and our wound nurses can help develop comprehensive treatment plans that address both of those conditions. We need a shared approach which includes compression garments or bandaging. So compression therapy, we would break down into compression bandaging, medical grade, and compression garments, also medical grade, which can help improve that venous return and support lymphatic drainage, reducing the swelling and preventing complications. So manual lymphatic drainage is a specific massage technique that stimulates lymphatic flow, and it helps to manage swelling and improve tissue health. It's more than just gentle touch and moving fluid, and it's often performed by therapists who have completed only a basic course or touched on it in their diploma of remedial massage training. So these therapists with scant training probably don't realise the impact that they're having on these systems and that the potential there is there to cause harm. Regular physical activity and weight management, skin care are all essential components of managing our vascular disease and lymphedema, and these measures can improve circulation, reduce swelling and prevent complications. And in severe cases, surgical options such as vein ablation or lymphatic bypass may be considered to address underlying vascular or lymphatic issues. So both vascular disease and lymphedema share several risk factors, and these include these four categories here. So excess weight increases pressure on the veins and the lymphatic vessels and impairing their function. For example, it's going to be really difficult to move fluid out of a leg if a patient has, so they're wearing their underwear, then they're wearing their outerwear, jeans or a dress or a denim skirt or something, and then they've got an apron or their abdominal adiposity sitting on top of those inguinals. So it's going to be difficult for the body to move that fluid naturally. And so we need to look at this in patients that are seated for long periods of time. Another one is lack of physical activity, which reduces our muscle contraction that aids in venous and lymphatic return. So you should probably all be aware that blood is moved around our body by our heart pumping, and lymphatic fluid is not moved unless we move. So we need to have some activity to be able to make that lymphatic fluid move, and a sedentary lifestyle, which we would see in our elderly patients, makes it difficult for that fluid to move out. So we need to look at different things we can do for that population. Regarding aging, so age-related changes in vascular and the lymphatic system can increase susceptibility to both conditions. And then procedures involving lymph node removal or vascular damage can disrupt that lymphatic flow and lead to lymphedema. And an example of this would be our breast cancer patients. So they have lymph nodes removed, they may go on to have chemotherapy and radiation, and that will affect their lymph nodes and the ability to move fluid out of that limb, and they will end up with, or they may end up with some lymphedema. But there's ways we can manage that as long as we get on top of it early. So the coexistence of vascular disease and lymphedema can complicate diagnosis and treatment. For instance, swelling caused by venous insufficiency may initially be mistaken for lymphedema, delaying appropriate care. Conversely, untreated lymphedema can exacerbate vascular issues by increasing tissue pressure and reducing that oxygen delivery. In the image on the right, you've seen these legs just earlier. The compression stockings have made a huge difference to this lady's quality of life. They support that blood return back to her heart, and they reduce the pain and fatigue in her legs. So the photo on the left, and in case you're wondering why this lady is sitting on a chair with a weeping leg on a bluey, on carpet, there was no way in Hades we could get this lady onto a massage table. So we just surrounded her with blueies. She actually can't lay supine or get in and out of a bed. So she's in a recliner chair. So in some of these pictures, like I've taken, all care and done my due diligence to make sure that these patients are looked after. So this lady has peripheral artery disease. She has lymphedema and she has wounds, and each of these conditions make the other worse. And she had no end sight. Like, she just continued on this vicious cycle for about 3 years. So these wounds were quite extensive, but in less than a week of bandaging with Compre 2, which actually is not meant for peripheral artery disease, but she had significant fibrosis. So in consultation with a company rep and her GP and myself, we decided to put her in Compre 2 for 2 sessions. So she did 3 days and then 2 days, and she was very, very carefully monitored. She has good cognition. She had family support. The GP was on the phone, so she was well taken care of. But during that time, we managed to reduce down her leg by 16 centimetres, and the wounds, you can see, are starting to heal. So when she first presented, she actually couldn't open her toes. Like, she couldn't move her toes at all because they were so lymphodematous. And so it took her husband and myself probably a good half an hour to try and bandage her toes to try and get that fluid down. And she came to me after that 3 days, like ecstatic that she could actually move her toes and clean between her toes. So something simple like a bandage and a multidisciplinary team really restored this lady's quality of life. And she's now actually being able to get into a bed. But once we reduced down the fibrosis with 3 days of Compre 2 and then 2 days of Compre 2, we were able to do an ABPI successfully, which did show that she had peripheral artery disease, but she was within the limits to be able to go into the next step down of compression bandaging. And we didn't use short stretch because it's just too messy with the wounds. So her husband and herself do the wound management, and I did the bandaging, and then they managed this at home, and they popped in every 10 days or so just to check on what was happening. So like with that holistic care and a multidisciplinary team and someone that really wants to go above and beyond, we can make a real change to our patients. So a multidisciplinary team approach is essential for managing patients with both vascular disease and lymphedema. And our key strategies include each of these 6 images here. So we've got compression therapy. And once upon a time, it was difficult to put a patient that had peripheral artery disease into compression because we just didn't have the availability. Nowadays, the companies have been able to develop compression bandages that are suitable for patients with peripheral artery disease if they've got a reading of just like above 0.5 and under 0.8. We've got a special style for them. We've also got companies that have developed compression garments that are suitable for people with peripheral artery disease, as long as it's within the guidelines and not under 0.5. We'll talk a bit more about those in a few slides. So then we've got manual lymphatic drainage, which is that specific massage technique that helps stimulate the lymphatic flow and reduce swelling. They need to look at some low impact activities. And now I've got swimming here. Obviously, a patient with a wound is not going to get into a pool. That was an image that I found, but we've got like just gentle walking, Tai Chi. There's lots of things that people can do to increase the exercise in their life. And then skincare is a really important one. So maintaining healthy skin reduces that risk of infections such as cellulitis, which can further compromise lymphatic and vascular health. So keeping our skin well moisturized and supple means that it's going to be, it's going to take a knock a little bit better when it's got that bounce in the skin. And it's also, when it's moisturized, it's going to help prevent infection. And then, of course, in severe cases, we have got surgical and pharmacological treatments to address those underlying vascular issues. Moving on to the Ankle-Brachial Pressure Index, or the ABPI, in clinical practice. So when I teach decongestive lymphatic therapy, each of my students, I teach them how to do a visual and a palpatory vascular assessment within our scope of practice. And then we each have an ABPI, and it's usually, 1 in 8 students will have some sort of issue with their arteries. And so, that's for referral on, but it lets us know that we need to be more careful when we're bandaging them in a classroom situation. So understanding that ABPI, it's a simple non-invasive diagnostic test, and it assesses the presence of peripheral artery disease. It measures the ratio of the systolic blood pressure at the ankle to the systolic blood pressure in the arm, or the brachial. And so this ratio provides valuable insights into the arterial flow and helps determine whether compression therapy is safe for patients with conditions such as lymphedema and vascular disease. So an ABPI is only useful for peripheral artery disease. It's not for venous disease. So one important thing to note here is that it needs to be the highest brachial systolic pressure. So if you're working in a practice that has anything but a 4-cuff lead, then what happens is you're going to need to do the blood pressure in both arms, and then you need to place the blood pressure cuff on the arm that had the highest systolic pressure. So the old Messy machine, it was a 3-cuff. They've upgraded that now to a 4. So if you happen to have the older Messy 3-cuff, maybe go back to the company and talk about getting that 4-cuff, because 4 cuffs makes life so much easier for yourself and for the patient. So what happens is you put that blood pressure cuff back onto the arm. If that happens to be the at-risk arm or the lymphedema arm, by now the patient's becoming quite stressed and getting that white coat hypertension. If you happen to put the blood pressure cuffs on incorrectly and you've got to do it a 3rd time, by now you've got venous congestion and you're not going to get a true reading anyway. So I happen to have a SmartDop XT, which is a 6-cuff system. It does the arms, then it does the toes, and then it does the ankles. And so it just reduces down that strain or stress on the patient. So some of you might be wondering if you can put a blood pressure cuff on an at-risk limb. Yes, you can. So there's lots of documentation. You could easily Google that and find the latest documentation from the Anaesthetics Association. I can't think of the name at the moment, but it is safe to put a blood pressure cuff and take blood from an at-risk limb. Of course, the patient has the right to refusal. And you want to get it right the first time. You don't want to be mucking around doing blood pressure cuffs several times. So if you've got a patient that's at risk of lymphedema and you're not confident with putting the cuffs on, find someone that is, so that the patient has less chance of getting that venous congestion. This is an example of what this particular reading from the SmartDop XT looks like. They're all fairly similar, but you can see down the bottom, on the bottom of the right-hand side of the page, it has the ABPI results. These are actually my results, and you can see it's got red for the ankle brachial, and then it's got blue for the toe brachial index. So there's no international standard for the readings for an ABPI machine, but every device comes out with their recommended ratios. But of course, the GP or the vascular surgeon is going to make the final call, because it's not only that ABPI result, we also need to take in the patient's health history. So we need to be looking at things like renal disease, diabetes, wounds, previous history, and things like that. So ultimately, the GP will make the decision, or the vascular surgeon, on the type of compression that this patient should have. Of course, it's usually in conjunction with someone like myself, a decongestive lymphatic therapist, and we're trained to measure and fit for compression garments and all the ins and outs of it. Alrighty, so tailoring our compression therapies, so where are we up to here? So the ABPI results guide the selection of compression bandaging and garments for patients with borderline ABPI results. And so that would be, if I go back a page, so we've got here, so moderate 0.5 to 0.7. We would normally go 0.7 to 0.9, so that mild pad we can put into bandaging and garments, but we want to do this making sure that our patient has good cognition. We've got a medical person like a GP on board. We don't make this decision on our own as a decongestive lymphatic therapist. So we do collaborate with GPs. So monitoring and adjusting the treatment. So regular monitoring of the ABPI ensures that the chosen compression level remains safe. And what that means is, if we've got somebody like my lady with significant fibrosis, we would do a second ABPI on her in a couple of months just to see where she's at. And diabetics can have a couple a year, but pretty much there's a whole new topic on ABPI about anyone that's over 65 with significant history, or anyone over 50 with significant history should have an ABPI, and anyone over 65 can have an ABPI as part of their health history, the health thing that they do once a year. Looking at our adjunctive measures, so when compression is contraindicated or limited, we could have alternative treatments such as simple elevation, or the sequential intermittent pneumatic compression, or lymphatic drainage is prioritised. And just as a side note, there is a specific SIPC, or sequential intermittent pneumatic compression pump, specifically designed for patients with peripheral artery disease, and I've got that in a couple of slides just to show you. Preventing complications, so making sure that ABPI measurements help prevent serious complications such as ischemic ulcers, tissue necrosis, or compression-induced pain. And we need to educate our patients about the interplay between PAD and lymphedema to ensure better compliance and self-care. If we tell them what's going on and the results that they can expect, then we're going to get more compliance. So not everyone is suitable for compression therapy, and not even ABPI related. Like, there's some people that can't don and doff. They've got no way of getting the garments on and off. They've got no arm strength. They have got very poor cognition. So some of our precautions would be those borderline ABPIs. We could use low level of compression. We need to monitor for signs of discomfort, pain, or skin changes. So like our diabetics as well. Other contraindications, or ones that would be contraindications, are those severe arterial insufficiency, patients with peripheral neuropathy. So that could be chemo-induced peripheral neuropathy or diabetic neuropathy, acute conditions like infections and untreated wounds, undiagnosed pain, untreated or undiagnosed cancer, and inability to communicate. So if they've got cognitive impairment or anything else going on, then we would be very careful about doing that ABPI and doing compression therapy. So an ABPI is an essential tool not just for diagnosing PAD, but for integrating care across multiple disciplines. For vascular specialists, it provides a baseline for treatment decisions. For lymphedema therapists, it ensures safe and effective management of chronic swelling without compromising arterial health. And for wound care specialists, it supports that development of holistic treatments, or a treatment plan for non-healing ulcers and wounds. All right, have a bit of a chat now about tailoring our lymphedema management plan. So there needs to be a holistic approach, and we know that in healthcare we need to have a team. We can't go it alone. So effective management of both PAD and lymphedema requires addressing the interconnected nature of these conditions throughout that multidisciplinary approach. So for our vascular health, we want to look at lifestyle changes within your scope of practice, as far as smoking cessation, prescribing exercise, looking at dietary interventions, and then there could be some medical interventions as well. From a lymphedema-specific intervention, we look at compression therapy, manual lymphatic drainage, sequential intermittent pneumatic compression, and adjunctive therapies. So those adjunctive therapies would be SIPC, but also low-level laser, deep oscillation therapy, things like that to help support the treatments that are happening already. With our wound care management, we need to make sure that the patients use advanced wound dressings and techniques to support healing in pad-related ulcers. And sometimes that can be a deterrent for patients because the wound dressings are so expensive. And so that's another reason why patients aren't getting optimal care. Compression bandaging, and then incorporate those decongestive therapies, which we talked about a little bit earlier. Monitoring and adjusting, so regular reassessment. We need to look at as the wounds and heals, then we look at adjusting our compression levels and the type of compression that we use. We may go from compression bandaging and move down to compression garments or compression wraps. Our patient education, so teaching our patients how vascular and lymphatic systems interrelate, making sure they understand about skin care, exercise, and early intervention for infections. So teaching them how to recognise cellulitis and recognising that deterioration in their peripheral artery disease, chronic venous insufficiency, lymphedema and wounds. So DLT, or decongestive lymphatic therapy, is the gold standard treatment for managing lymphedema and vascular disease. It comprises 5 key components. So we've got compression therapy, which is garments or bandaging, manual lymphatic drainage, which is just gentle massage techniques moving towards the heart, exercise, which could be low impact exercising such as swimming or walking or Tai Chi, obviously around wounds, skin care, so the skin hygiene and moisturization to prevent infections and maintain that skin integrity. And then we need to educate them and offer adjunctive therapies. And some of these adjunctive therapies they can do themselves at home, others they need to see a therapist for. So I've got some of those listed there and we've talked about those just previously. So the role of decongestive lymphatic therapy in wound healing is to reduce swelling, prevent complications, enhance that immune response. So MLD stimulates the lymphatic system, enhancing the removal of waste products and supporting the immune response to infection. It improves skin health. So the skin care component of DLT focuses on maintaining skin integrity and preventing that breakdown, which is essential for wound prevention and healing. So things like lymphorrhea. So if we've got really good skin care and compression bandaging, we're going to reduce our risk of lymphorrhea in our patients. And then we need a holistic approach. So DLT addresses not only the physical aspects of wound care, but also the emotional and psychological well-being of our patients. So by integrating these best practices into wound care protocols, healthcare providers can optimise outcomes for patients with lymphedema and vascular disease, improving their quality of life and reducing the risk of complications. There's some key components of a comprehensive management plan. So before we can even implement DLT or decongestive lymphatic therapy, we need to complete a comprehensive lymphedema plan. And this is essential to address the unique challenges of the condition while improving the patient's quality of life. And so that consists of a comprehensive assessment. We want to conduct a detailed medical history and a physical examination to identify the cause, the stage, and the severity of the lymphedema. Patient education, so teaching patients how to recognise early signs of complications such as infection like cellulitis. Goal setting, so collaborating with the patient to set realistic measurable goals for that symptom management and restoring mobility and improving their quality of life. Multidisciplinary collaboration. So we need to involve a team. We can't do this on our own, and we need to, go back to our doctors and our wound care nurses and our decongestive lymphatic therapists and dietitians and podiatrists, even mental health professionals to help provide that holistic care. And then we need to regularly evaluate the patient's progress and adjust accordingly. So implementing best practices in wound care for patients with lymphedema and vascular disease. So as mentioned, the gold standard treatment for vascular disease and chronic wounds is that lymphedema, and lymphedema is compression therapy. But first we need to make sure that it's safe to apply this, and so we need to do that ABPI. Some common wound issues are our venous ulcers, arterial ulcers, and combination wounds. So some of these can really complicate lymphedema or the treatment of lymphedema, and that's where we need our multidisciplinary team to step in. So regarding pathophysiology, reduced arterial perfusion in PAD impairs the delivery of oxygen and nutrients to tissues, which slows down that wound healing. In lymphedema, protein-rich fluid accumulation creates a breeding ground for infections such as cellulitis and doesn't help wounds heal, so non-healing wounds. Regarding improper wound care, chronic wounds can lead to infections, including cellulitis or osteomyelitis, and in advanced cases may result in critical limb ischemia or amputation. So effective wound care prevents infections, reduces inflammation, enhances healing. It addresses the underlying cause, such as improving circulation, reducing swelling, and ensuring proper skin care. And this is just a picture of one of my clients who presented with cellulitis. I actually put her in an ambulance and sent her to the hospital, and they've drawn exactly around the edge of the cellulitis. When I do it in my practice, I go about 5 mil above the cellulitis and I just dot a dot around. I don't put a pen over the cellulitis because it's an infection and it's quite sore. So best practice for wound management, we need proper hygiene. So regular cleansing of wounds with gentle, non-irritating solutions to remove debris and prevent infection, and having that meticulous skin care to reduce the risk of breakdown and infection. And we have a lot of problems with skin folds. So a lot of patients, they don't check underneath their apron. A lot of women with big breasts and cognitive issues and wounds don't check underneath their breasts. So we need to make sure that we're checking our patients in their skin folds and making sure that they don't have a wound in there. And if they do, if it's not our scope of practice, refer them out. Moisture management, so using dressings that maintain a moist wound environment, such as hydrocolloids, hydrogels, or foam dressings. Exudate control for heavily exudating wounds, consider superabsorbent dressings and alginates, and infection prevention, applying antimicrobial dressings. We need to have frequent assessment of wound progress to detect early signs of infection, delayed healing, or deterioration, or if we're on the wrong path. And we need to monitor systemic complications like fever or worsening ischemia. So so compression therapy aids wound healing. So in this diagram, this is a picture of the arterial sequential intermittent pneumatic compression pump, and it can take up to about 6 months of very, very regular use of the patient. It's like one patient use, and they wear this every day, a couple of times a day, and it helps with arterial pathways. And so I can send out some information on this if anyone is interested, but I haven't covered it in this chat because I won't have time. But compression improves venous return, reducing venous pressure and edema. It also enhances oxygen and nutrient delivery to tissues. That ABPI we should have to ensure the safe application of compression therapy. Bandaging may be our first line of treatment, but it may not. We may have to go straight to a garment, and the garment doesn't necessarily have to be a pull-on stocking. It could be something like a wrap, which is a lot easier for patients to don and doff, or get on, take off. Educating our patients on the proper application techniques to avoid uneven pressure or constriction. So proper skin care and infection prevention are critical for patients with lymphedema and vascular disease, as these conditions compromise the skin's natural barrier and increase the risk of complications, such as that cellulitis and delayed wound healing. Once the patient has cellulitis, they're at an increased risk of recurrent cellulitis, and some patients have cellulitis like perpetually. It just doesn't go away. We need to maintain skin integrity by regular cleansing, moisturizing with hypoallergenic and fragrance-free moisturizers, looking at invention protection, so promptly cleaning and covering any cuts and scratches, avoiding trauma, and then those regular skin checks. I feel like I'm going to run out of time. I've got so much here to say. Wound care in patients with lymphedema and vascular disease requires a specialised approach to address the unique challenges posed by these conditions. So we need to do a comprehensive assessment, and that actually means we need to measure, like evaluate the wound, and this is where a wound care nurse actually comes in. They take photos, they measure the depth and the size and the width of a wound, they look at its condition, the surrounding skin, and they document all of this. Debridement, so we'd be performing gentle debridement and then maintaining a moist wound environment using appropriate dressings. A lot of patients think that they need to dry out their wound when we do need some moisture in there for wound healing. Techniques for managing wounds in patients with compromised lymphatic and vascular systems. So compression bandaging or garments to manage oedema and improve venous and lymphatic return. We need to avoid tubey grip. Tubey grip is common in GP practices, and unless it's applied correctly, all it does is tourniquet or cause a champagne leg. So tubey grip shouldn't be used, but we used it a lot to hold dressings in place when we've got skin integrity that can't take any sort of tapes. But if we're going to put tubey grip on, it needs to come from the toes to 2 fingers below the popliteal, and it should be graduated. So we should put another layer over that, 2/3, and then another layer over that to 1/3. It's best to completely avoid tubey grip at all costs. It just causes issues. Infection management, so using antimicrobial dressings, consider systemic antibiotics, so the GP would implement those. Looking at our adjunctive therapy, so we could use negative pressure wound therapy or bioengineered skin substitutes for non-healing wounds that have been there for a very long time, and teaching our patients and caregivers proper wound care techniques, including dressing changes and infection prevention. If they can manage some of this at home, it's going to cut down the cost to them as well as the burden on the health system. A lot of the time, the patients won't pay for the dressings, though. They don't realise how expensive they actually are. Collaborating with our team. So we have a big team when we're looking at lymphedema, wound care, vascular disease, peripheral artery disease, and this is just 4. There are many others. We've got dietitians. We might have physiotherapists that can organise exercise routines for them. We'd have occupational therapists come in, making sure that their environment is safe. While they've got these wounds, they need to make sure they've got the right footwear and things like that. And this happens in any order. So I will quite often see a patient come to me that has not even been to see their GP because they don't want to bother the GP. And so I do my assessment and then refer them back to the GP, who will then refer them on to a vascular surgeon if required, or get their wound care nurses involved. So it's a really big team, and we need that collaboration because it improves patient outcomes through holistic care, addressing both vascular and the lymphatic dysfunction. It also, if we've got that team, it's going to reduce the risk of complications such as infection and delayed healing. If we've got someone if we've got the whole team there that can look after the patient. A big thing is in educating and empowering our patients through self-care. And we can beat our head against the wall sometimes trying to get our patients to do self-care. We can just do what we can do. So education equips patients with the knowledge and confidence to actively participate in their own care, reducing that dependence on healthcare providers, and it improves their outcomes. So it empowers patients to adhere to treatment plans and detect early signs of complications. They take timely action to prevent worsening conditions. The other thing that I do is I give my patients, I've got lots of information sheets, and this is just one of my older ones that I give to patients. So we need to get them to do some self-lymphatic drainage. So it's a simplified version of manual lymphatic drainage that patients can perform themselves at home. We just need to make sure we teach them the right way to do it, and we need to teach them the appropriate pressures. So when I'm teaching them, I will get them to palpate my arm so that I can titrate their pressure, particularly if it's a husband helping a wife. Husbands are notoriously heavy. They think they're doing the right thing. If they've got some fibrosis there, they want to really get in and massage it. So I get them to massage my arm so that I can titrate that pressure for them. So I always make sure that I do a practice in the consultation. I get the patient to go through the entire sheet with me and do that themselves. And if they've got a carer there, I get the carer to do it as well. Proper wound care, so making sure that they are observing hygiene at home, washing their hands, keeping pets out of the area where they're doing dressings, making sure that they've got a clean area and meticulous hand hygiene. We need to also look at dressing maintenance, so providing guidance on the selection and application of appropriate wound dressings. And this can sometimes be a huge barrier because of the cost of the dressings. Patients don't want to pay that price for the dressing, but if they had the proper dressings, then their wounds would probably heal a lot quicker. Skincare, we've talked a lot about that, so moisturising and teaching patients to inspect their skin daily and making sure they reach out for help if they've got a problem, like not sit there thinking, oh, I'm okay, I don't want to bother anybody, a quick phone call or pop into the surgery to see the nurse, make an appointment, just to make sure that things are going along okay for them. Using compression garments. So again, we want to make sure that patients know how to put this on. In my practice, I have some samples and I get my patients to actually put a sample on before I'll order it for them. And I have lots of donning and doffing aids and gloves, and I get them to do it without the donning and doffing aids first. And then I give them the donning and doffing aids and show them how easy it is to do once they've got the right equipment and the right compression stocking. So you need to make sure that that's properly fitted, make sure they understand how to care for that garment, and understand that they actually only have about a 6-month lifespan. So I've got some patients that have been wearing the same garment for 10 years. It works. I don't know. I think it's just psychosomatic. And again, when to seek help. So they're not a bother. They need to give you a call and get in touch if they've got some problems. Resources to support. So it's always a good idea to have some educational handouts or brochures on self-lymphatic drainage or wound care, compression therapy for patients. I sometimes will give a patient a tape measure and just pick a scar or something on their limb and just say, you know, this is a measuring point for you to just see how you're going with your compression garments. Sending them to or recommending support groups. Recognising early signs of complications. So we need to educate our patient on wound complications, what to look out for, those lymphedema complications, so sudden increases in swelling or heaviness. We need to be really particular about that because, and I always refer those back to a GP. If we can't find a reason for that sudden increase, we would be considering or thinking about metastases. So I'm always really mindful of those patients. If I can't drill down to how that has happened, like they've just walked a dog or done some cleaning or travelled, I'd always want them to have a checkup with their GP. And then vascular issues. So if they've got any increased claudication or any increased rest pain, we want them to be seen by their GP. Continuous learning and professional development. We're nearly there, guys. So the field of lymphedema and vascular disease management are constantly evolving, and there's new research every other day, new technologies. Like we've got the HiverMat now in Australia, which is a sensational machine for moving fluid and working with musculoskeletal pain. It's just the bee's knees. So that's, you know, an advancement that I'm using. There's lots of new treatment approaches emerging. We've got lots of new bandaging options, lots of garment options now that are actually there for different demographics. So it's not just one size fits all. We've got a lot more off the shelf garments now, so we don't have to have custom made. The companies are really looking at and broadening their sizes so that we've got a much broader size range for our patients. We need to look at improving our patient outcomes, so ensuring that patients receive the most effective evidence-based treatment, and we can only do that if we stay on top of our skills. So enhanced skills and knowledge allows professionals to refine their skills, adopt innovative techniques and expand their expertise. Compliance with best practice, so staying informed about updated guidelines and protocols ensures adherence to industry standards and regulatory bodies such as APRA. Adaptation to emerging trends, so awareness of new technologies such as those advanced compression devices and diagnostic tools, and getting training. So many companies offer CPD that you can, you know, go in and learn about these emerging trends, and that gives you professional credibility. So it demonstrates a commitment to ongoing learning. So basically, in summary, we've talked a lot about understanding lymphedema, vascular disease, and peripheral artery disease. So a comprehensive understanding of these conditions and the correct treatment regime is essential to be able to manage our patients holistically and effectively. Collaboration among healthcare professionals ensures a tailored, patient-centered approach that addresses both physical and psychosocial needs, empowering our patients through education and self-management, so teaching them how to look after themselves, and then staying updated on advancements in lymphedema and vascular disease management is vital for us as therapists and clinicians. So this is my personal opinion to barriers to best practice. So from a health professional's point of view, we have lack of knowledge. So when we complete a degree, we're given a very broad education. Some things are just glossed over. We spend a lot of time on research and how to do peer-reviewed articles. But basically, a lot of things are just a taster that we can do within our scope of practice. It's up to us to go and find education, credible, accredited in education on these tasters if we feel that they're our calling. And mine was lymphedema, so I went to great lengths to learn about lymphedema. So you cannot possibly be a wound care nurse or bandage a leg with what you've learned in uni. It's just a taster. And so that's probably why we see a lot of tubing grip in practice. I don't know. These are just all my personal thoughts here. And you cannot offer manual lymphatic drainage on what you've learned at massage school. And so there's a lot of people that are doing MLD and they don't even realise that without understanding why they're doing it and how fluid moves and what happens when it gets there and where does it go when it gets there and what are the complications, that they could inadvertently be causing damage. We have a lot of Chinese whispers. So we have different therapists and nurses and all sorts of modalities learning off each other. And so it's a bit like Chinese whispers. By the time it gets to the last person, they've missed a lot of steps. We have limited resources. So in private practice, patients expect, this is my opinion, patients expect that their consultation is going to include everything. And so buying bandages, they actually have no concept of the cost of some of these bandages that they actually need to heal their wounds in a timely manner. And so they avoid, well, practices just probably don't stock them because it's just not in their scope. ABPIs are rarely done. Accessing a wound clinic can be really challenging. So we need to be able to explain the benefits of gold standard treatment to our patients. From a patient's point of view, they lack knowledge, so they cannot fathom that a wound takes time to heal, and that paw ointment is actually not going to fix it. So they can't understand that a wound needs to be moist for healing to take place. A lot of our older generation, they want wounds to dry out. Now, those top 3 photos are actually my dear old mum at 80. She fell over on Boxing Day and she did a significant amount of damage to her both hands and her arm. And I took her to the emergency department and she was given the best treatment ever. She went back to the wound clinic there, and mum is a really slow healer, but within 3 weeks, her hand had healed to that degree. Now, she is a patient that just wanted to go home, put paw ointment on it. She said, no, I'll be fine. Just take me home. That would never have healed. And so if patients don't accept that there are treatments out there, then we're not going to be able to help these patients. Lack of funding is a big thing. They can't afford the bandages. Isolation, they can't get to the treatments. And attitude, I'll be right, I'm okay. Just give me some paw ointment. I don't want to bother anybody. In the bottom picture, that's my dad, and he had venous eczema for about 3 years. And this was many years ago when I first learned how to do decongested lymphatic therapy, and I put him in compression therapy. He was my first patient to put into some compression therapy, and I put him in some jopes for men. And after 7 weeks, that middle picture is the response after 7 weeks of compression. Now, my dad actually had peripheral artery disease, undiagnosed, and it wasn't until I've had all this training that I realised that that's what happened. My saving grace was that Dad worked at Vinnie's, and so he brought home everyone's secondhand stockings, so there was no fear of him ever being damaged. From having worsening condition of his peripheral artery disease. So there's lots of barriers to getting good care, and we need to try and bridge those with our patients and our staff. So the knowledge and skills you've gained today, I'm hoping you've gained something from this, are powerful tools to make a meaningful difference in the lives of individuals living with lymphedema, lipedema, vascular disease, peripheral artery disease, and many other conditions. And by integrating these insights into your practice, you can enhance patient outcomes, build stronger, trusting relationships, and contribute to the advancement of care standards in your field. Some further training, we'll chat about that another day. And we might stop sharing now and we'll go to some questions if there's any questions there, because I've probably taken up too much of your time already. Thank you so much for listening. It's been a great webinar. I'll just come back now.
Thanks, Jackie.
All righty.
Yeah, so if we have any questions, feel free to pop them in the chat now, and we'll get to as many as we can before we hop off. But again, we'll send out an email after the webinar that has answers to any of the questions we don't get to. So I did have a question there earlier from Rebecca. She was asking for alternatives on the tubing grip. If you have any preferred, what's your preferred?
Yes. So my preferred method would just be to use a crepe bandage to hold on the dressing, or contact a company and find out if they've got something else on the market. There's so much out there and they're continually updating, but I would definitely avoid chibi grip because it tourniquets, it's a false risk, it causes that champagne leg effect and it causes more trouble than it's worth. So maybe a crepe bandage would be a start.
Excellent.
Nothing else there?
I'm not seeing any other questions for the moment.
It's a really big subject and there's so much that I missed and there's lots of gaps to fill in, but hoping that there was some information there that you could take away today. Of course, we all need to work within our scope of practice, and we all need to, keep our doctors, our GPs involved because at the end of the day, they're the ones that can make those decisions for us.
Excellent. Well, I think if there's no other questions, if people do think of questions, keep an eye out for that email that we'll send across to everybody. We'll put links to, Jackie, your website and your contact details as well for people to get in contact if they have any questions that they think of from then. But I think we'll leave it here for now. So thanks
happy
so
to
much,
answer
everybody.
Happy to answer any questions that come through. You can email me if you like, or give me a call.
Fantastic. All right. Well, thanks, everyone. Have a great afternoon. We'll see you next time.
Thank you.